a role which he's held from 2015 to 2017. And then last but certainly not least, we have Mark Atkinhead. Now, and he is a doctor. He has his PhD in anatomy from Queen's University in Belfast. Hold on, I'm scrolling up. He is a global commercial leader and a clinical next generation in sequencing division at Thermo Fisher. So gentlemen, welcome, and we are so lucky to have your knowledge and experience. I have a couple opening questions for a few of you, and then we'll go ahead and get into the Q&A for the entire panel. So first up is Dr. Eisman. Doctor, what's the biggest myth you hear from patients about COVID that you want to clear up today?
Well, thanks for having me today. There are so many myths that it's hard to prioritize them. I think the biggest one is it's just a hoax. It's just like the flu. And people can cite all kinds of different statistics to try to support that particular viewpoint. I think this is not the flu. This is much, much, much more serious than the flu. And it's different in so many different ways. For example, we don't have any vaccine as we do for the flu. We don't really have effective therapies for this particular viral illness like we do with influenza. And the consequences of this disease, although there are people with the flu that get very sick, the consequences of this disease are really profound. They involve multiple organs, not just people's lungs, but your brain, liver, kidneys, cardiac. And so it's just a much, much more profound illness that is, I think, had a much greater impact on so many people.
Great, really appreciate that. Next up, we have Dr. Ma. We keep hearing people are afraid to go to hospitals because you have COVID patients. Are we correct, or are folks correct to have fear? Are your hospitals overrun with COVID patients?
Yeah, good afternoon, Scott, and thank you for hosting. That's a great question, and I think we still battle with that. You can understand it's not really irrational. What's the first thing we did was really kind of lock everything down, and I think we did a good job of asking people stay at home, don't go out, don't go to hospitals. But unfortunately, what has happened is there's been a little bit of a misalignment between the initial messaging and maybe the realities of where we are in healthcare today and in hospitals today. And as a result, there have been significant unintended consequences of that. And you'll hear more and more about that. What people refer to as the invisible patients, or what is felt to be a looming health crisis as a result of many people not seeking care until it's too late. And those unintended consequences have resulted in various states, such as New York, as an example of having an increase in heart disease-related deaths of 398%, diabetic-related deaths of 356%. And so this disconnect, I think, is what's really driven various health organizations and even our health officer for San Diego County to come out and really implore people to remember to seek care when they need it. Because the reality is that we don't see transmission of this disease in healthcare. Early on in this disease, we had, within this county, the hospitals collectively gathered data on the transmission in hospitals. What we found is in healthcare providers, looking at over 15,000 of our providers in this county, the incidence of disease was on the order of 1%, which is about 5 to 6 times less than what we see in the community. And that's consistent with what we see is that people gather this disease in the community when they're out and about. And it's because of the protocols we all have in our hospitals. When you enter Tri-City, you're going to actually walk through a scanner that assesses your temperature and even reminds you if you don't have a mask on to put your mask on. We do, of course, attestations and screening for all guests and all of our employees. And that's consistent across the board for all hospitals. Enhanced cleaning schedules, testing of patients before surgery, testing of patients as they're admitted to the hospital. And so in many ways, you've created more of a safe zone in the hospital. And I think that's why you see such low incidence and you actually don't see transmission of disease to patients in hospitals. And so I do think that that public health message of seeking care when it's important, when you need that care, don't forget to see your doctor for your blood pressure. Don't forget to pick up your medications because those consequences can be dire.
Great, and really appreciate you clearing that up. Thank you for that.
Sure.
And then last, we've got Mr. Atkinhead, and your initial question is, we keep hearing that we have these fast 15-minute tests, but then people get tested and it takes days for the result. Why is that?
Yeah, thanks, Scott. Pleasure to be here. Thank you very much for having us. So I work at Thermo Fisher Scientific, and as you noted, I work normally in clinical oncology in the sequencing space, but I've been very fortunate in the last 20 plus weeks to really help coordinate our local activity for COVID testing. And Thermo Fisher is now perhaps the largest supplier of COVID tests worldwide. We're making about 10 million tests per week of our own full assay, as well as components for many other tests. So as a result, millions of patients around the globe are being tested on something that's in many places is coming from actually elements within Carlsbad, within our own facility here in Carlsbad. Your question's a good one. If these rapid tests are available, why does it take such a long time? Why are we seeing 4 and in many cases actually much worse than that turnaround time, which is really very, very poor? There's 2 pieces to that question. Let me address them slightly separately. The first one is, why does it take such a long time? And the second, where's all these rapid tests? So the first part is that the test itself is really complicated. This is not a simple assay. It takes a long time. The gold standard today is that a medically qualified professional will take a swab, will administer that swab, package it, send it to a qualified lab where it'll be processed and turned around. That actual process of taking this patient swab and turning that into a result, it's actually only about 3 or 4 hours, depending on which type of equipment used. The challenge, though, is how you get it there. It's normally not administered in the same place. You've got to find it in that equipment. You've got to move it, transport and transit those swabs as materials. They've got to get then accessioned into a system, and all of those processes are adding additional time. And so there's a clear need, therefore, for faster, accurate tests. The challenge, though, is that as we've seen the market come out with, additional test opportunities, 15-minute tests, 8-minute tests, of those are somewhat compromised from that gold standard. You're making different steps away, whether that's self-administered, whether it's saliva, whether it's these small portable devices. So we're seeing there's an ever-present activity to drive new technology into this space, but ultimately the standards are really about meeting that gold standard of that full administrator test. And I think secondarily, then the piece has really been the impact has been around supply. Can we meet that supply, the supply of really critical materials, both on the sort of standard tests as well as on these rapid tests? And that's the simple reason that we're not seeing 15-minute tests everywhere, is that simply the manufacturers cannot meet the supply. Companies like Thermo Fisher, as I said, will build 10 million tests, but that's a drop in the ocean of what's actually probably truly required. So it is a question of supply, and we will see improvements in speed and turnaround time as that supply chain improves and technology improves to meet it as well.
Great. Thank you very much. That's, again, incredibly helpful. And I think our 3 panelists have really set the stage now for kind of the next set of questions. Again, don't feel, for our panelists, don't feel that you have to respond. However, I'd like responses to each of these. So here goes the first question. Again, I'll open it up to any of our panelists. People keep saying they already have COVID, or if they've had COVID, do they develop an immunity from COVID? And again, kind of one of those, is this a myth or is this a reality? Folks?
Well, it is really too soon to know how many people who actually have had COVID, documented have had COVID, could then get reinfected. What is true, and we've seen this in a number of cases, is COVID is not just a discrete one episode problem. People sometimes, not always, get sick, come to the hospital, get better, go home, and then have relapses of their original illness. Does that mean that they got reinfected, or does that mean that it's a continuation of their initial problem? This particular virus causes a whole cascade of inflammatory events in your body. And whether those events stop at some discrete moment in time or continue to smolder and reemerge is hard to distinguish between that and getting a new infection. So what we hope is, of course, is that developing certain immune responses to being infected, or much more importantly, to a vaccine, will ultimately confer immunity or a great deal of immunity against getting infected. I think that remains to be seen. I think we're hopeful that the vaccines that are now being tested in phase 3 trials are going to be effective. They appear to be effective in conferring immunity, but that has to be tested in a very large number of people in a very rigorous way to really make that determination. So the answer is no one really knows at this point.
Okay.
Yes, Scott, if I could add to that, I completely agree with what Dr. Eisman said there. And I think one word of caution is that we've seen many patients who've actually had COVID, confirmed COVID, but their antibodies are not positive 6 weeks out, which is the IgG that we test at that time. And again, the data suggests that it really correlates with the severity of illness. If you're asymptomatic or have mild disease, the degree of immunity or antibodies that are developed are very, very mild and may not last very long. And it may be that if your severity is worse, it may last for longer. But these are all very much unknowns. And there is a second component to it, is that we're looking for antibodies, but we don't know now that that's not a complete picture of the immunity. There's actually T-cell mediated immunity and other forms of immunity. So you don't just have the Marine Corps as your defense. You've also got the Navy. You've also got the Army, so to speak. So you've got multiple arms of defense. But I think the warning right now is I would not assume just because you had the disease, you are immune, because I think that potentially could lead people down a path of false sense of security.
God, so true. I really appreciate that statement. Dr. Atkin, had anything to add?
No, I think that this is the nature of dealing with a novel disease. You know, if you imagine that it was early January, we really had no information at all. I've seen evidence. I was just watching local news last night, and they were talking about antibody testing in Del Mar, for example. I'm not sure what that would tell me. I'm not sure what it really informs me. I guess I have an intellectual curiosity to find out, have I been exposed to the disease? I think every one of us who've had a sniffle at all in the last few months have asked that question, but I don't know what it would do in terms of changing my behavior. I would still believe I would need to follow social distancing, best hygiene practices. I would still, think very carefully about how I interact within the community, because I don't know that it necessarily confers anything. And I think that the two medical doctors really spoke very eloquently about the concern. We really do, at this point, not really truly understand exactly what the immune response will look like.
Okay, great, thank you. Well, then let me move on to the next question. I'm told only people with pre-existing conditions are getting hospitalized and put on ventilators. Is that true or false?
That is patently not true. It is statistically true that people with pre-existing conditions are at risk to develop more severity with the illness. So, for example, if you have chronic lung disease or diabetes, or you have immunocompromised state for various reasons, that if you contract COVID-19, your risk of developing more severe disease is greater. That is true. But we have had many examples, and I think Dr. Ma will tell you this. This has been known throughout the city, that there are many people who have heretofore been very healthy individuals who get very ill with this illness. I think one of the really critical things to understand is people look at very important indices such as mortality, for example. Clearly that's important. But there is very significant morbidity with this illness. You can get very sick without dying, and you can get very sick without being on a ventilator. We've become better at keeping people off ventilators by a variety of different strategies, but the illness is very protracted in many patients. We currently have a 52-year-old gentleman upstairs, previously completely healthy individual. We have another 60-year-old individual that have been both on high flow oxygen, not on ventilator, laying on their stomachs to help improve the oxygen delivery into their bloodstream for a month and a half. A month and a half on your stomach. You have to think about that. So it's not only about being on ventilators, and it is absolutely not true that being previously healthy somehow confers a guarantee that you will be less ill.
Great. Well, and again, remember, this is myth busting for our all of our attendees, and thank you for that, because one of the things that's always confounding is we get, here in the city of Carlsbad, we end up receiving a lot of questions as well, and it's amazing what occurs in a situation like this, potentially, or especially when it's protracted. Everyone becomes a medical professional. It's the craziest thing. Whether they have a degree or not, suddenly they're everybody's resident expert. So I cannot thank each of you enough for being on this panel and continuing to do a little.
Well, one quick thought about that is, I get that. I think everybody, understandably, is incredibly anxious. It's a big unknown. I think that holds true for not just patients and the general public, but for all the healthcare workers, physicians, et cetera. We're not trying to scare people. This is not about scaring people straight. This is about telling people the direct information so that, as one of our panelists just said, you can make rational decisions that are appropriate and help us get through this time. This is not trying to just freak people out.
Right. Yep. Good point. Well, then the next kind of myth-busting question to ask is, I keep hearing that masks don't really help. Is that correct?
I can take that one. I can start that. I think that's absolutely incorrect. Am I freezing up here?
No, we can hear you fine.
Sorry, am I freezing there?
Nope, we've heard you fine.
Oh, okay, great. Yeah, for every 10 studies, it seems like that you'll see that demonstrate the value of masks, and we're getting more and more data every day. A recent study looked at the kinds of masks, even from cloth masks, and now you hear about gaiters being a major problem that actually may disperse more virus than even not having a mask. For every 10, you'll get one that will say that masks are not beneficial, and a lot of that data comes from previous experience with influenza and similar other viruses and SARS. But the reality is we're getting a large body of data that clearly suggests that it's beneficial, and most importantly is we're seeing epidemiological data, and we're looking at countries that previously aggressively approached a mandate towards early adoption of masks, and you're seeing significantly lower. There's a study that just came out looking at over 198 countries, and the differences between those that really adopted early mask mandates versus those that didn't, you can see up to 100 times the mortality rate in those countries. And when in those countries, even when they actually relaxed those guidelines, you actually saw another spike. So it's very clear that masking does have an impact. And the type of mask, we are starting to see there are variations, but even cloth masks, the main issue is source control. It's really about controlling the potential risk of somebody that you have no idea, this asymptomatic transmission that could be spreading it. But if you control the source or the patient who potentially has the infection by masking them and preventing that large dispersal of virus coming out when they yell or scream or cough or even talk, the probability of increasing the viral load in the air and dispersing that in the air and making that transmissible drops significantly. And that's consistent with what we're seeing from an epidemiological standpoint.
That's great. But I do have a follow-up question for you, Doctor, because there was that, I think it was a Washington Post article that came out last week where they were talking about the wearing of gaiters, which you touched on a little bit, could actually be worse for people than wearing something at all. Now, I did find that conclusion was a little alarming, not to mention because I was one of the folks that really enjoyed wearing gaiters because of the convenience of being able to pull it up. I've since had to go away from that, and now I'm back to wearing a mask. But I did want to touch on that a little bit, or if you could touch on that, because it seems counterintuitive to say that any type of cloth in front of you would be, or at least the wearing of a gaiter would be worse than not wearing anything at all. So can you touch on that a little?
Yeah, sure. So that actually caught me a little off guard too. I was a little surprised. I mean, intuitively, it seems like any type of cover would be beneficial. But there are some questions about how well performed that study was. It's really kind of in a lab where they actually set up, measured what they could see from the dispersal of lasers to be able to assess catching these droplets. But what their theory is that the gaiters, and of course people breathe through them much easier because, we're looking at significantly larger gaps in a gaiter. If you stretch it, you can see through them. And it's really about the likelihood of catching the virus, right? You're looking at a 0.12 micron virus that, you're trying to filter down as close as you can to that. There's virtually no mask that can actually specifically catch 0.12. But the reality of it is they're in multiple layers. And so the more layers you have, the more likely you are to prevent that. But the gaiter suspicion is that the theory is that because it creates these little holes that are fairly large, when you're talking, you're now dispersing larger droplets into smaller particles that could potentially now travel further distances because they're lighter. I'm not sure. That's not really yet validated. And so most of us haven't necessarily aggressively pushed back against that yet because there's a tendency to want to at least get a little bit more body of data before we overreact or react specifically to one. But I think it's going to really pressure the you're going to see more and more studies that really assess whether or not that is reality or not.
Thank you. Anything to add from our panelists?
I guess my view of that would be, and I'm sure Dr. Mal would agree with me and our other panelists, that when you've been in this industry for a long time and practicing medicine or developing testing strategies, it takes a long time to understand what is really truthful and what isn't. And so one study does not necessarily just automatically change everything. What I do think is that if we know that things are safe, or we think that things are the safest things, surgical masks, for example, or using N95 masks for healthcare workers that are directly around COVID patients that are generating aerosol and droplets, et cetera, then we should do the safest thing. The illness is too severe. There's too much risk that we can asymptomatically spread it to other people in our community, to our families. My parents are in their 90s. I would be mortified if somehow I didn't take the precautions that I really needed to take in the best possible way that science understands to be the best at the time. So I would opt for the study that you mentioned. Maybe that gives me a little pause to be concerned. I probably would therefore want to be a little safer and make sure I distance, hand wash, and use surgical masks, more accepted masks like the one you showed, until such time as we have really definitive evidence that something is okay. I wouldn't take any one study immediately.
Great.
Better safe than sorry.
As Dr. Eisman said, I mean, I would agree with that. I'm not a clinical doctor, I'm a scientist, but I'm a skeptic as well. And so I took every piece of evidence in that same light. As a confirmed gaiter user for the last few months, I can tell you that I saw it with some sense of horror and shock. it's interesting because it's already changed my behavior, and I saw it and thought, I mean, if I'm being out running, especially on the paths and the trails where I feel like we have large opportunities where you're separated, but there's those moments on those trails where there's just that little bit of a bottleneck and you're going to be close to somebody at that moment. The gaiter was really convenient to be able to remove it and place it back on again. I don't know whether that behavior will change, by the way, just until I see more data. But if I was going to go to the supermarket and I'm going to a birthday party with some people, you know, which socially distance outdoors, but it's my neighbor who's in her 80s, I wouldn't think about that. I would go put on a proper surgical mask, and I would be very, very cautious about how I would approach those things. So I think we took all of the elements that we see in the scientific medical community, and we look at all of those elements in combination, and then make what we think is the right assertion. There is no question that social distancing, hand washing, correct hygiene, and a proper surgical mask are the most effective tools that we have at our disposal today.
Great, thank you. All right, then here's the next one, which actually was touched on a little bit in our opening questions by Dr. Aikenhead. But it's been reported that we don't have enough supplies to test everyone in the country. Is that true or false? Fact or fiction?
It's an interesting question. Let me tackle that. So do we have enough to test everybody in the country? The answer is almost certainly no. I mean, I think that if we were to paint the ideal world, if we had everything at our disposal, what would we have right now? It would be a at-home, cheap, super cheap, like less than $1, disposable, fast answer that would allow people to go and get some quality of COVID testing. The reality is we don't have anything like that. There is nothing in the space, and we rely, and we will rely for a very long time. And I mean, not just through the winter and through the flu season, but all the way through clearly next year and well beyond, on the gold standard of a PCR-based analysis tool. And while, you know, companies like Thermo Fisher have ramped up, now we're now at, you know, 10 million tests per week. That's nowhere close to what's required on a global basis, just given the number of infections that we're seeing across the community. So we will continue, we're committed to continue to expand that. We will continue step by step to build more. Other players in this space are doing exactly the thing. We're actually all very much cooperating to make that happen. But we need the technology to play catch up. We're playing catch up right now. I think locally here in San Diego County, I think we've done a really great job, and the county stepped in and with the different hospital networks and really provided in-hospitals testing is really there. I think that people who are symptomatic can get testing, and they can get testing quickly. But we don't have enough to be able to really do what a lot of people are looking forward to. We're now starting to turn our attention to like back to school and back to work initiatives. Mm-hmm. For those kinds of activities, we will need millions and millions of more tests per day to really to be able to take that next sort of step. So it's a double-edged sword. Yes, I do believe we have enough to meet the needs of the immediate symptomatic population, but I don't believe that we have enough to really get us back to some sort of level of what I think people are trying to drive for, which is that sense of societal normality.
Got it. Perfect, thank you. Then I'm going to go ahead and move on to the next question. Hearing people talk about hospitals being, quote unquote, incentivized to code patients as COVID positive, and that hospitals are getting more money to do so. Is this a fact or is this a fiction?
Well, I would take that. I think that's a fiction. I think that, and I bet Dr. Ma would agree with me, in San Diego, there is tremendous cooperation among all the hospitals at the level of the chief executives, chief medical officers, chiefs of staffs, and internally among each healthcare system to work together to take care of these patients. I think that the world that we live in of the emergence of conspiracy theory, hoaxes, etc., and I'm not now trying to be in any way political, I'm just saying that doctors, nurses, healthcare systems, all of our technical people that work on these things are here to take care of patients. We're not trying to game the system or to code in some particular way or have some business aspect of it. We are trying to have the proper personal protective equipment, as Dr. Ma correctly pointed out, protect our patients as all the hospital systems have adopted those similar processes to make sure we don't infect patients, take care of our workers, and of course, to contribute to the social awareness of what we need to do as a society to minimize the impact of this illness. That's what we're interested in. Everything else is frankly irrelevant.
Great.
Yeah, I would agree. That was really well said, Dr. Eisman. You know, we hear a lot of myths these days, and some of them I got to go look up and figure out, you know, is that real or not? But that one is particularly disturbing. And I think, you know, we as practitioners, as physicians, and as an ER physician, you know, you're here. That's not what you look at. You're there to take care of the patient first. The reality of it is that COVID patients are in hospitals for significantly longer periods of time, and hospitals are largely paid by what we call the DRG. So you're paid for what's largely what's called a medical DRG, which is you're anticipating a 3 to 5 day stay. When people are there for 9, 14 days, that actually is the complete opposite of what that question or that myth insinuates. So it's particularly disturbing, as I think, to hear that unfortunately the people do that's out there, because that's completely counter to what we do. So
Great. Well, and I just saw that we have our 5-minute warning that popped up. So if I could give each of our panelists an opportunity for kind of final thoughts or final statements before we exit the chat room. So let me go ahead and start with Dr. Aikenhead.
Yeah, I just want to say thank you very much for having us with us. We're very proud of the work that we've done at Thermo Fisher Scientific. As I said, parts of the components of those 10 million tests and the many others that are developed are actually handled by our team here in Carlsbad, and it's a super important part of that. Our efforts are really around the community, about ensuring that the tests that we manufacture, you know, are getting into the right hands, getting into the hospitals, into the private labs, into the skilled nursing facilities, and we look forward to continuing to expand that capacity. And to really, you know, make an impact within our local community. But it's all about the community. And so thank you very much for having us on board today from the city. Thanks again, appreciate it.
Thank you so much. And then let's go to Dr. Ma.
Yeah, well, thanks again for having me. It's been a real pleasure. I think we're really fortunate here in Carlsbad and this North County region to have Thermo Fisher and the great work that they're doing. You know, we also have Gilead here, one of their branches, which is the company that developed the remdesivir. I think one of the things Dr. Aikenhead mentioned that really struck me several times, and I really think that the things that we do are effective, and it's really important. What I started with is that in hospitals, you don't see transmission. It's because for so long, we've been really adopting the things that really Dr. Aikenhead really mentioned. And these simple things really give you control over a lot of the transmission of disease. He mentioned social distancing, hand washing, and of course, the primary measures of infection control that have always been in place in hospitals. Those are the things that really do impact and the masking too. So I think that's the takeaway message really here, is that you don't want this disease, and you do have some control. So thanks for having me.
Absolutely. And Dr. Eisman, bring us home.
Well, I wanted to again thank you for having all of us here. I very much appreciate it to help get our message out. I just wanted to, I think, I agree with everything that's been said. I would just add to it a message of hope. I mean, this is an incredibly difficult moment. And all the doctors, all of our people who develop tests, who are our nurses, respiratory therapists, everybody, hospital systems, administrators, all of us are singularly committed to helping the public, helping our patients. That's what we do. And if we can all just try to maintain our commitment to the policies and procedures that help us stay safe, keep this disease to a minimum. And I got to really congratulate a lot of people, what I see in the North County when I'm out and about, to be very, very careful and very thoughtful, compliant with all the measures. We're going to get through it. I think what we don't want to do is just try to scare people, but we do want to be clear with people so that we can get through it in the best possible way, take care of all of our other patients who don't have COVID, and we will come out through this on the other side. So it's a message of hope, really.
Great. Well, I just want to sincerely thank our incredible panelists. I got to tell you, I've been looking forward to this since they announced the three of you, because we could not have a better panel. I also want to thank the Chamber and Brett specifically, because, again, this was a fantastic idea. And I just wish that we weren't a breakout room panel, because, quite frankly, this is the most, I think, topical thing that's occurring right now. And I just, again, credit to each of you. Thank you for your efforts. And we'll go ahead and end our session now. And I think we'll jump out to the main room. Is that correct, Brett?
I think so. I'll just echo until they kick us out. Oh, we got 60 seconds. Okay. In those 60 seconds, I'll just echo my thanks to you, gentlemen, for being available today. And I know you're all extremely busy, so thank you. And Scott, to your point, we did record this, so we hope to share this message beyond just who took advantage of being in the room today, so the breakout room. So we will push this message out farther and wide. And so again, incredible information, and I just can't say enough. So thank you all. And we will be rejoining the main room here in a few seconds. And I understand if you have to go on your merry way, we only have a couple minutes left that we'll be doing to close out. But I know you're all in your offices, and so you got a lot going on. So again, thank you.
Thank you.
Yeah, thank you, Scott.
You're welcome. You guys take care now.
Thank you, everybody.